My name is Heather Moky, and I come from the University of Illinois Hospital and Health Science Systems. I'm a physio, and I'm here to talk to you about behavioral modifications and physical therapy options for treating male urinary incontinence in the post-prostatectomy patients. So I'm going to start out with some basic facts for you, and I want to let everyone know today that men have pelvic floor muscles. Okay, if you weren't aware, wanted to let you know. For so long, we've heard so much about women and incontinence and their pelvic floors, and they haven't really talked a lot about men, and noticing that men have incontinence too, which obviously you are all aware of, and that's why you're here today. And in average, there's a lot of different statistics out there. One is that 17% of men over the age of 60 have urinary incontinence. In addition to a staggering amount of financial cost of billions being spent every year in the United States to treat urinary incontinence, there's also an emotional and social cost of incontinence. When we look at statistics, we can see that up to 9 out of 10 men have some form of urinary incontinence after prostatectomy. It can be anywhere from a small amount all the way up to very severe. The problem when we start looking at the statistics is that little data is available on the incidence and the types of urinary incontinence or comparisons of racial and ethnic groups in recent literature. So as we get farther into these statistics, we may find that the numbers we're looking at with male urinary incontinence is actually larger. And few studies actually even look at male under the age of 40. So pelvic floor muscle strengthening is recommended as a first-line treatment, and that has been established in a variety of many different studies. And here we look at a study from Van Kampen et al. From 2000, looking at 102 post-radical prostatectomy patients with incontinence. The treatment group was a pelvic floor re-education program for as long as they were incontinent for up to a maximum of 1 year, which is very extreme in some measures, but the reality was they were just going up to see what continence was like 3 months afterwards. In the treatment group, 43% of the 48 patients, or 43 patients of the 48, for a total of 88%, were continent after 3 months, compared to the control group, where only 29 of the 52 patients, for 56%, were continent after 3 months with no intervention. Here's another study from phila cameo et al. In 2005, looking at 300 radical retropubic post-prostatectomy patients, and in the exercise group, after 1 month, 19% had achieved continence, and after 6 months, 94.6% had achieved continence, where in the control group, 8% at 1 month and 65% at 6 months. And you look at the difference between the 6 months being either 95% or 65%. Well, if you're in that 30% that's incontinent, you're not going to be very happy. Now, it is to be said that sometimes there will be spontaneous healing in incontinence, but that can take up to 1 to 2 years after the surgery. And that also depends on the level of incontinence you have. Another question I get many times is, do you want to start your pelvic floor training before surgery, or do you want to look at it start it right after surgery, and when do you start it? The most recent research out is by Garrett et al. In 2013, and they looked at doing the experimental group started pelvic floor muscle training 3 weeks before surgery for 1 session each week, and the control group started the training right after the catheter was removed. The conclusion was there was really no difference in the duration of the incontinence. However, with actually talking to some of the researchers, they said they find that their patients are happier and have a little better confidence when you do the training prior to the surgery, because they feel more prepared and they feel like they know what to do prior to going into surgery. So either way, whether you start it before or after, you're going to have about the same amount of incontinent time, but you will have sometimes a little more satisfied patients if you start prior to. And there are research studies out there that do support the role of starting it prior to surgery. So we can talk all day about research, but I'm going to just throw out a couple more additional studies here. Bauer et al. In 2011 once again recommended pelvic floor muscle training is recommended for the initial treatment of stress urinary incontinence. However, there is no random controlled trials to compare non-invasive techniques to invasive techniques. It is noted that when patients have urgency urinary incontinence, in addition to the pelvic floor training, you should add an anti-muscarinic therapy as well. We're going to go into also additional aspects when we're looking at a systematic review from 2006. They were looking at pelvic floor muscle training with or without biofeedback. Does that increase continence faster? And in this particular study, they said either way, it's increasing continence faster in both those groups compared to no pelvic floor muscle training in men with urinary incontinence after a radical prostatectomy. So I'm going to tell you a little bit about what I do from the evaluation aspect. And when a patient comes in, we do a variety of intake forms, outcome measures. We will go through a subjective and a past medical history. I ask them a variety of different questions about their bladder habits, their bowel habits, sexual functioning. So we get pretty close and intimate right away with my questioning. And then I go in to do an education piece of understanding their past medical history, how it affects them, where they are in a healing and recovery stage, and also the anatomy of their body and the physiology of the area, getting specific with the pelvic floor muscles. And I'm able to spend time and really educate them on what are their pelvic floor muscles, where are they, what do they do, how am I going to assess them, because I will do a digital rectal exam at some point during therapy. If it's right after surgery, I speak with the doctor to make sure we're on the same page of when he wants me to perform that. And also, how am I going to get them stronger and have them understand how these muscles works and how they can take control to help improve their situation. So I also like to educate patients to think of their body as a house. Tell them your abdominals are your front door, your back and spinal muscles are the back door, your roof is your diaphragm, and your foundation is your pelvic floor. So, sir, how important is the foundation of your house? The most important. So right there is usually the response I get many times from every patient. So that just gives a good, scenario for them to understand how important these pelvic floor muscles are. So, and then I'll continue on, and I usually have them change into a gown, and then I will do an external pelvic assessment where I'll look at the pelvic area and the perineum. I look at the skin, I look at the incision site, ask about pain issues, palpate. I'll look at reflexes. I'll do a perineal assessment. I'll ask them to contract and relax. Then I'll continue on, and I will do an internal pelvic assessment with their approval. And I use the Laycock's Perfect method, where I look at the power or the strength, where I grade it from a 0 to 5 scale. I look at endurance. Are they able to hold a contraction up to 10 seconds? I look at repetitions. Are they able to repeat a 10-second contraction up to 10 times? And I look at quick flicks. So I'm assessing both fast twitch muscle fibers and slow twitch muscle fibers. So as you see on the bottom of the page, you see the 3, 10, 8, 6, and that is a way I will assess their strength. So 3 is the strength of the pelvic floor, 3 out of 5. 10, the patient was able to hold a contraction for 10 seconds. They were able to repeat that contraction of 10 seconds for 8 repetitions, and they were able to complete 6 quick flicks before fatigue. Now, that's a very generous grading system right now, when usually we'll see not able to hold a 10-second contraction right away. So after that, I usually have the patient get dressed, and then we sit down in my office and we talk about what are their goals. Doesn't matter what my goals are, I have to find out what their goals are, and are they willing to buy what I'm selling? Because if they're not, they don't want to do exercises, then it might, be just a referral back to the doctor. And also you got to figure out how to motivate your patient as well. We'll talk about the prognosis and the importance of adherence to therapy and in compliance on their part. I explain the treatment plan, and I'll issue a bowel and bladder diary if I haven't done so already, and we'll instruct on a 24-hour pad test. And just to include on the pad test, in physical therapy, it's a good way for the patient to do that, sometimes once a week, sometimes every day if they want, if they're really bad, because it's a good way to track their progress if they're measuring it correctly, or they can bring it in and I can measure it. We use a variety of different outcome measures that are very important as well, and it helps track our progress to be able to compare in contrast to where we're doing good. But also now you will find that it's important for insurance reimbursement, and some insurances are making it essential that you do these things to get an increased rate of reimbursement. And the treatment plan I need to mention is a very individualized treatment program. Now, the focus is going to be of pelvic floor muscle strengthening and behavioral modifications, but in that assessment, I also assess their whole body. I look at other aspects that maybe are weak and need to be strengthened. Are they able to contract their pelvic floor muscle with breathing normally and not holding their breath or performing a Valsalva maneuver? We'll look at scar mobilization, core stabilization, and also getting patients back to return to cardiovascular exercise, even if that's simply a walking program. So, and then we get into, at future visits, behavioral modifications. We'll look at the bladder diary that I sent them home with. We'll talk about different voiding mechanisms, time toileting, leakage strategies, and exercises. So here's an example of a bowel and bladder diary. And right away, we can notice if we look at the liquid intake, this person drinks a lot of caffeine. So that tells me they're dehydrated, there's no water. Then we can continue. A bladder diary will tell you what type of incontinence this patient may have. And we can see when we look at the leakage over on this side here, we'll see that leakage is happening with coughing and sneezing, sitting to standing. So that's stress urinary incontinence. But we will also note too that there's urgency noted when they're leaking. So this patient may have a combination of urge and stress. So a bladder and bowel diary can give you a lot of information that can help you in treatment. I also use this too to assess constipation, to make sure they're getting proper fiber. When you notice in the bowel, the little star is that the patient had the urge to go to the bathroom but was unable to fully defecate, also confirming the fact that there's some constipation issues going on, pushing down on the pelvic floor. So the bowel and bladder diary can give you a lot of information, but I also like to educate patients what is normal. You ask many patients on how often they should be urinating or how many times getting up at night, they have no clue. Or how much fiber is proper or water, they don't give the right answers. So we'll continue on looking at behavioral modifications, and one is the urge protocol. It's a technique to learn to delay the urge to urinate. Another one is the knack. It's you squeeze before you sneeze, or you squeeze before you cough or stand. A lot of times men will report that as they go from sitting to standing, there's some loss of urine. So you teach them to do a pelvic floor contraction prior to standing and learning to hold it, so to retrain those muscles. We also look at breathing and different toileting positions. Then we'll go into pelvic floor muscle strengthening. It's really important and crucial that the patient is able to isolate their pelvic floor muscle and perform a contraction. We look at both the strength and the endurance of the contraction. We want to make sure there's proper breathing and the patient is not doing the Valsalva maneuver. And then we will train from a supine position to sitting to standing to making functional movements while activating their pelvic floor muscles to get them back to different activities and possibly higher level activities. Each patient is given a home exercise program. They're taught the importance of personal responsibility. They're given the toileting and leakage strategies, exercise routine for pelvic floor muscle training, as well as a core stability and anything else that I have found in the evaluation that could benefit them, as well as encouraging them to get back to a cardiovascular exercise program. I'm also will educate on stress relief and the importance of that with these patients dealing with cancer diagnoses, probably other treatment related to cancer as well. And with any patient, they're educated on posture and body mechanics and how they need to have proper posture to help their muscles. So what if it's not working? So then we go to our tool bag, and first of all, to a certain degree, if a patient wants a quick fix, I tell them I don't have the easy button to push to say, here, you're fixed. It's something they have to commit to and work on and make it part of their life. So it's encouraged to educate on patients and the importance of compliance. If a patient is not able to isolate their pelvic floor muscles, we look into different options of biofeedback or electrical stimulation to assist with that. If that's still not working, I'll look at more involved options of other PT techniques or incontinence tools, and we'll talk with the doctor or send them back for further evaluation by the doctor. So when we look at electrical stimulation and biofeedback, Goods et al. Did a study where they had 3 groups. They had a behavioral therapy group, they had a behavioral therapy group in office with biofeedback and daily home pelvic floor stimulation, and then the control group was a delayed treatment group. And when they looked at that basically, in this particular study, the behavioral training group and the behavioral training group plus biofeedback and pelvic floor stim had the same results, and it was at least a 55% reduction in the incontinence symptoms. So this is one of our biofeedback systems that we use. And then we also use the real-time ultrasounds. Do people use the real-time ultrasounds in the crowd here at all? Great. I was going to say it's a fabulous tool. And here's a study back from 2005, and it basically shows you that the real-time ultrasound is a useful adjunct to assess the function of the male pelvic floor. It has good reliability and it's less invasive than doing digital rectal exam. However, there are complications to be noted because there can be scar tissue, and as well as the ability for patients to maintain a full bladder so that you can get a clearer picture. Now, interesting enough, just recently, Stafford et al. In 2012 released a research study looking at male pelvic floor contractions through transperineal ultrasound and showed some fascinating results. And it was mentioned earlier, at first people thought, well, female incontinence and male incontinence are very, very similar. Well, then we all got wise and realized they're not at all. And this is a great technique that's used to compare the relative displacement of the urovesical junction, the rectal junction, and the distal urethra during voluntary contraction, and it gives us more information, which is a great option that just came out. But what does this all mean? Is that first of all, pelvic floor muscle strengthening is recommended as a first-line treatment. There's many tools out there to help you achieve that. You need to individualize a program for your patient and have the patient take self-responsibility and also know how to motivate them. What else may your patient need? Sometimes stress management, relaxation techniques, other incontinence tools and educations. We've mentioned penile clamps for different options here. In severe cases, that has been things I've used probably twice in my career. Psychological support or counseling to deal with the different diagnoses that they're dealing with. Nutritional referrals, social work case management, support groups, and always referring back to the doctor for additional procedures. Resources. There's a variety of resources out there, but you also have to know what your facility offers, what your community offers. Starting a support group, because there is training available. You want to find good resources for your patients, because as a physio, we have more time with them and they depend on us for more information. And so I like to have different aspects for resources, even if it's not in my hospital. And also I have a binder in my office of different resources where there's support groups in the areas for the patients in case they may want them. So just making a couple notes. US2 is an international prostate cancer education and support network. It has 320 support groups worldwide, over 12 countries, and they offer training to help you start a support group, and they will send informational pamphlets. And so that's one option. There's other organizations all over the world, from Australia, there's a Switzerland, so I'm just noting these down. And there's also a lot of online options for your patients too. One question you guys may all have is, how do you find a good physiotherapist if you don't have one? How many of you do work with physios? Okay, so that's good to see. And if you don't, there's a variety of online networks to help you find physios too. You can go through the American Physical Therapy Association. You can go through the International Women's Health Association to find physios in your area. And you can always contact me and I can help give you references in the area of the world you guys work in. So at that point, I'm going to open this up for any questions.
And thank you very much for this excellent presentation between overview and practical management. Are there questions out there? Please.
I will try. Do you know at beginning of treatment what's this prognosis of your patient?
Well, it's very difficult to fully answer that because there's a lot of things that go into it. You know, what type of surgery they had, how much incontinence are they having? Obviously, less incontinence, is better outcomes. Also, how motivated is the patient? Are there comorbidities? So unfortunately, I can't give you, a definite good prognosis, but that's why it's really important to find out what the patient's goals are, how do you motivate them, and impress upon the importance of compliance and making sure that they're able to independently isolate the pelvic floor musculature. Now, right away, the less amount of urine in the pad test is going to be a good indicator to get patients drier quicker, as well as, if they don't have comorbidities, as well as the compliance factor too. And also, if they're able to contract their pelvic floor muscle independently, that's going to be better outcomes as well.
And about the bladder hyperactivity, do you use tibial neuromodulation?
Oh, different modalities. Do I use tibial nerve stimulation? It's an option I have. I typically don't use it that much, to be honest. So, but it's nothing I've been currently using at my current place of employment. But it is an option. There is research out there that shows some benefit to it.
Okay, thank you.
I have a question, Heather. Here.
Oh,
sorry.
I was like,
if I understood you correctly, you recommend to start the pelvic floor muscle training right after the catheter removal?
yes.
Because there are different colleagues who recommend the patients to wait 3-4 weeks and start
And that
really late after catheter removal.
Right, and that's based really on the repertoire you build with your doctor and having that communication of when they want you to start that as well. I don't just automatically start it. I usually will check or see how far post-operatively they are. But some of the studies by Moky et al. Are catheter removal and they start pelvic floor training. Now, with that being said, you're usually not doing a max contraction at that time, but just starting to facilitate.
Heather, can you please comment about a common practice, at least in US, to discharge the patient, tell them go online, get the Kegel exercises, and then they are coming back with an extreme fatiguing their muscle?
Fatigue, or then you may see some increased tone in the pelvic floor muscles. And that's one of the really important things, that even if you send a patient to a physio for one visit, my job is to make sure they're doing it correctly and that they're not valsalvating. When they are trying to do it and they're doing it incorrectly, you will find you can get some increased tone in those muscles that can also lead to pain issues as well. And so, it's important to talk with your doctor or your physio about those issues.
Concerning the idea of starting the training even before the surgery. Now, one of the problems is that the patients might not want to be on the waiting list too long for the surgery, so there's very little time. So can that be more than just learning what they should be doing afterwards, or do you think you can really build up some sphincter activity before that?
And what the research has currently shown is, I don't believe that, depending how soon that you're really beefing up prior to surgery, but you're getting the patient to understand what they're supposed to do and
Afterwards.
starting neuromuscular facilitation and being able to identify. But after surgery, there's so many different things going on. There's swelling, there's pain, they're distracted. So sometimes it's easier to get better attention beforehand.
Yes.
And as I mentioned, I did speak with a couple of the researchers who've done research in this area specifically, and they said you're not going to get your patient drier faster necessarily, but they do seem to be happier and more confident. And ideally, who doesn't want a happier, more confident patient? Because if they're confident in you as well.
So I believe it's more a learning type thing before the surgery. By the way, a question to the urologist: is anybody afraid of having somebody start pelvic floor training too early after the surgery, in order of compromising the anastomosis or anything like that?
If that's the case, I would really encourage you to work closely with your physical therapist, and discuss. I mean, anytime I have any questions, I email my doctors, I call my doctors, I text my doctors, and, when in doubt, I always check it out. And that's where I believe a lot of the doctors that I work with have faith in me to know that I know what they want as well.
Okay, any other questions? Then thank you so much. I think Erwin is really happy to have you around.